Oh, okay, you're in. Hello, Allah. Hello, can you hear me? Allah or Nahar? It looks like you're on mute.
Yes, I can. Hello.
Oh, good. Hi. Hi, Nahar. Are you moderating?
Excuse me, I did not hear it very well.
Oh, okay. I'll speak slower. Are you moderating today?
No, I'm just a participant.
Oh, okay. Okay. Don't worry. Don't worry. Hello, Allah, are you there? Your microphone is muted. Hello, you're not live, you're not on. Allah. Ah, you're here. Okay, good. Hi.
Hi,
How
I hope you
doing?
can hear me now. We have
Yes, yes. Okay, you're gonna be the moderator, right?
yes,
Okay, I'll introduce you, and then basically run the show. Now, you can do what you want. Now, I need to communicate with you during the webcast, okay? So I'll do that by chat, okay? Or you want to do Facebook?
okay,
Well,
okay, no worries.
I'm talking about during the chat. You know, I may say, hey, the sound is off, or the person's camera is wrong. You know what I mean? I need to communicate with you,
Yes,
okay, during the webcast.
okay, no worries.
Okay, good.
Okay, I will keep my messenger open.
Okay. Yeah, people are coming late. Sometimes they come late to concerts, especially in Latin America. All of them are late.
Okay, I will send on our page that we are live and
Okay,
remind
okay,
people that we are right now on.
okay,
Okay.
okay. I'm the only lonely guy.
Okay, let me just check the our page. We are live. I'll put also the link
Okay.
if they miss anything. Okay.
Don't worry, I'm still here. I'm just setting up. Okay.
Okay. I sent a
Yeah.
reminder for people, so you
Yeah.
can say,
I'm here. I'm just setting up. We'll wait a few minutes for more people to come, as well as the speaker.
We can stream this on YouTube, right?
Yeah, I'm putting it on YouTube right now.
Okay. Well, Dr. Matis is telling me he's online right now. Okay.
Hey, are you communicating with Georgio's Allah? Hello, Allah, your camera's off.
Yes, he's telling me that he's online.
Yeah, your camera's off, Allah.
Yes, you can hear me.
Okay, yeah. You are communicating with him?
Yes, he's telling me, I think, on Instagram.
Are
Yeah,
you,
just a second.
are you talking to Dr. Matos? Are you talking to him?
Yes, I'm talking to him. Just a second.
Oh,
He's
okay.
sending me
Okay,
on Instagram.
Okay, no
Okay.
problem.
Yes.
Oh, I'm sorry, he's here now. He was in the waiting room. I didn't see him.
Okay, he's saying that he is
He's here,
online
he's
right
here.
now, but
Hello,
Hello.
Doctor.
I just
How
can't
you
see
doing,
him.
Dr. Mathis?
I'm fine, thank you. Thanks for helping us out here.
Yeah, sure. Thanks for taking the time. You're
pleasure.
traveling now, right? Are you in Berlin now?
Now here I'm in Cologne, it is 11 o'clock.
Oh, okay.
It's a normal time.
Okay. I'd like to wait a minute or two, okay?
Mhm.
Because a lot of people come late.
Okay, let's see.
As you know,
Hello,
are
Dr.
you on a
Mate.
tight,
Thank you
tight
for
schedule,
joining us today.
Georgio? I'm sorry, what did you say, Allah?
No, I was just saying thank you for Dr. Mates for having time to join us today.
Oh, okay. You've never met Dr. Mathis online, right?
No, actually, we've already met and we have some work to be done.
Oh.
But not in real life.
Yeah.
Oh, okay. Yeah, you spend a lot of time online.
You noticed.
Yeah, you like it. Well,
I
you
like it.
use it. You use it well. You spread the word of
Exactly.
what you're doing.
It's a part of the job.
Yeah, it's good. I mean, it's hard for me to impress upon kids the
Yes, exactly.
importance of building your image from the start. I mean, you show up and you make your presence known, you introduce yourself to people. It's a great tool.
Yes, but you must sacrifice your private time as well.
Okay, let's see. Georgio, we'll start, okay?
Mhm.
And people will come in as we go along. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting, and I'm glad to say that we're restarting the Walter Dandy webcast. And today we have a new chapter, the Syrian chapter. It's headed by Allah Hamdan. And she's going to introduce the speaker, Georgio. Hey, Georgio, welcome.
Hi.
And she's going to run the program. Welcome, Allah. It's all yours.
Thank you very much, Dr. John. Well, I'm thrilled actually to introduce to you Dr. Georgio who is joining us today to speak about spinal cord stimulation in the back pains, chronic back pains actually. He is a senior consultant, head of the Department of Pain and Spasticity in the clinics for stereotactic and functional neurosurgery in the university hospital and the clinics in Cologne. He is also the co-chair of the Medical and Public Education and Engagement Committee of the International Neuromodulation Society, and we are looking forward for the presentation today. Thank you, Dr. Mates, for joining us, and the word is yours.
Thank you very much for your kind introduction. Thank you very much for the invitation. I thank the Dante Club of Syria for this invitation, and also you, John, for organizing this. Thanks for helping us always with all our events. Let me share my screen. Please let me know if you can see it.
Yeah, perfect, George.
Okay, then let's start the agenda. Over the next minutes, I would like to speak about the current role of this therapy in the interventional pain management. I'm going to show you how we got to these new spinal cord stimulation systems that we are having, why I believe that a new era has begun in this field, and how I think it's going to be the future of spinal cord stimulation. The problem with chronic pain, not only back pain, but all forms of chronic pain, is that it is subjective. We cannot really know how it feels like to have chronic pain. It's exactly the same. We don't know how it's like not being able to hear or being able to see something. The chronic pain patients are difficult patients. They have many problems at the same time. Here you are seeing a part of the pain detect questionnaire. It's a questionnaire we're using to see if the pain is neuropathic or nociceptive in nature or something in between. And the patient here should tell us how severe the pain is from a scale from 0 to 10. She wrote down these numbers. It took us some seconds to realize that she wrote down her mobile phone number and not the intensity of the pain. This is something I found on Instagram. This comes from Brazil. This is a way to treat back pain. We have such as well. But we have also the interventional pain therapy as a more scientific way to do things. In this context, we can act at the level of the first neuron. Here we have the dorsal root stimulation therapy, the pulse radiofrequency, the subcutaneous leads, or the stimulation of peripheral nerves. At the level of the second neuron, we have spinal cord stimulation, the topic of today's talk, and the intrathecal therapy with or without opioids. And the level of third neuron, we have motor cortex stimulation and deep brain stimulation. The talk is about chronic back pain, but let's not forget that we have a variety of conditions that we can treat using spinal cord stimulation. For example, trigeminal neuropathy, not neuralgia, neuropathy. Patients, of course, with radiculopathies, with phantom and stump pain after amputations, with polyneuropathies. The best examples are diabetes patients or patients after chemotherapy. Patients with plexus lesions, if the lesion is not complete. Patients with angina pectoris, with peripheral vascular disease, with post-herpetic neuralgia and complex regional pain syndrome type 1 or type 2, with or without capsalgia. It is true that nowadays we have a paradigm shift away from the traditional World Health Organization analgesic ladder toward an earlier surgical intervention. This is a very interesting paper published from Slavin and McGuire in 2020. And this is the traditional World Health Organization ladder. You probably know we start with non-opioids, then we try to use the weak opioids, then the strong opioids, and then we have the intrathecal therapy. But we have seen that if we start with all our neuromodulation options, for example, the pulse radio frequency, or the peripheral nerve field stimulation, or spinal cord stimulation, before even starting with the weak opioids, then the clinical results are much better. And this is true because the concepts are really changing over time. A very nice paper, it's about the history of the synapse. Here you can see all the great minds of humanity being included in this article, which shows how what we believe about the synapse, our concept about the synapse is changing over time. It's exactly the same with the treatment of chronic pain with spinal cord stimulation. Spinal cord stimulation, just to speak the same language, it's about implanting 1 or 2 leads in the vicinity of the spinal cord, stimulating, applying electrical impulses, and if the patient is satisfied, then connecting these leads to a permanent battery, to a permanent neurostimulator. It is not a new therapy. Everything started with this article published in the Science magazine in 1965. It's a famous gate control theory. And 2 years later, in 1967, we had the first clinical application of this therapy in a patient with lung cancer. The colleagues back then implanted a lead. It was an experimental procedure back then, but the patient was satisfied. He experienced a substantial pain relief, but unfortunately, he passed away 6 days after the surgery because of endocarditis. Which are the targets when we're using this therapy? Actually, we're stimulating the dorsal columns and we're stimulating the dorsal horns. We have segmental effects, meaning that we are acting at the level of the spinal cord, but at the same time, there are supraspinal descending inhibitory pathways. And in this photo, you can see how a spinal cord stimulation could look like with 2 leads and the permanent battery. In Germany now, this is the history of neuromodulation, the first spinal cord meeting in Freiburg in 1967. Colleagues came from all over the world back then. And back then, we had such devices. These are the famous receivers. These devices didn't have any battery, but they were implanted under the skin. And each time the patient wanted to stimulate, should use this round thing, this round antenna, over the receiver in order to get the stimulation. These were the very first steps. The leads. We have the possibility to use percutaneous leads, more simple leads on the left part of the screen. We have the possibility to use bundle or surgical leads on the right side of the screen. Back then, the colleagues started with leads with only 1 contact, then with 2, with 4, with 8, and nowadays we have leads with 16 and 32 contacts. This is what we see after the implantation of the leads. On the left side, a lead with only 8 contacts. On the right side, 2 leads with 8 contacts. Another option is to implant leads with 16 contacts, 1 or 2. There's only 1 lead in the market with 16 contacts, and we were very happy and very proud in 2018 to be the first European center to implant this lead. We have the batteries, the IPGs, the neurostimulators. Here we have 2 options. We can use a non-rechargeable one on the left part of the screen. You see it's bigger. The whole battery is inside, but if after 1, 2, 3 maximum years, we have to replace it because the battery is empty. And we have also the option of rechargeable ones on the right part of the screen. These are smaller. There is a battery inside, but the patient has to charge it once or twice per week. Every 10 to 12 years, we should replace this IPG as well. Spinal cord stimulation, as all therapies, has some indications, some contraindications, and we have many patients who are in these gray zones. Here in the images, you can see my home, the University Hospital of Cologne. My department is located on the 14th floor in this building. These photos were taken at 6:30 in the morning. In Germany, we have some guidelines with some inclusion criteria, some exclusion criteria. Inclusion criteria, actually all patients who have tried everything else, medications, physical therapy, all other types of therapy, and they still have chronic pain. Exclusion criteria, and these are even more important, patients with severe coagulopathies, mental disturbances, addiction problems, secondary gains, if, for example, don't want to go to work, inability to use the system, advanced mild gland tumor, if we know that the patients are not going to survive after 2 or 3 months, we don't implant such a system, and of course, infections in the area of implantation. The majority of patients who are coming to us are suffering from this failed back surgery syndrome, or the new term persistent spinal pain syndrome. According to the literature, we know that the failure rate of a lumbar spine surgery lies somewhere between 10 and 46%. It's pretty big. And we also know that although more than 50% of the primary spinal surgeries are indeed successful, no more than 30%, 15%, or 5% of the patients experience a successful outcome after the second, third, and fourth surgeries, respectively. This persistent spinal pain syndrome, or patients with chronic back pain after surgery, are not the only patients who can benefit from spinal cord stimulation. One example are patients with scoliosis. This is a very interesting article published in Neuromodulation Technology and the Neural Interface. It is the official journal of the International Neuromodulation Society, showing that in patients with scoliosis who were not candidates for another corrective surgery, the pain relief within the first 6 months was somewhere between 30 and 40%. This is not an impressive pain relief, but it's clinically relevant. Other indications which are really good for this therapy are the intractable angina pectoris. Here we implant a lead with a tip at C7 or T1 on the left side, paramedian. One question that I hear really frequently is what happens if an infarct comes, a myocardial infarct comes, the patients will notice this new acute pain. Spinal cord stimulation cannot mask it. And a second indication which is really good for spinal cord stimulation is the peripheral vascular disease, stages 3B, if it's possible, 4, in some cases 4. Here we plant a lead for the legs with a tip at T10 in the middle area, in the middle line, and you can see on the right part of the screen what happens with our stimulation. It's the control group. You see the colors are green. Green means that there's not so much blood in this area and the temperature is low. And what happens 30 minutes after the activation of the system, you see the color is completely different. You see it's becoming red, meaning that the perfusion in this area, the blood perfusion, is much better, the temperature is increasing, and the pain relief is also following. CRPS, complex regional pain syndrome, within the first year after the onset of symptoms, could be a very good indication for spinal cord stimulation, and this is something we see also in patients with chronic back pain. If you're interested in the topic, this is a review article published in the British Journal of Neurosurgery. I think it's a very nice review. And in the second journal, we have published one more article, a review article, a systematic review about peripheral vascular disease. If you don't really like reading articles, you could watch on YouTube this interview. It's about spinal cord stimulation and peripheral vascular disease. It takes only 30 minutes. We are speaking about spinal cord stimulation, but let's don't forget that we have the possibility to combine therapies. We can have this hybrid stimulation. For example, in this case, we can combine spinal cord stimulation and peripheral nerve field stimulation. It was a patient with a bicycle accident. You can see the scar. Back then, many years ago, the colleagues implanted 2 leads parallel to the scar under the skin and connected these leads to a neurostimulator. Some years later, the patient came back with more severe pain. Then we added a spinal cord stimulation lead in the epidural space and connected it to a neurostimulator, and the patient is still happy and he can still use his bicycle. We talked about leads, we talked about neurostimulators, but all these things are important because using them, we can apply different types of stimulation, different waveforms. The gold standard is the tonic stimulation, a stimulation with a tingling sensation. The patients are getting paresthesias. But now we have many more new waveforms without this tingling sensation, without these paresthesias. These are subperception waveforms. And why is this important? It is important because, at least the way I see it, spinal cord stimulation is like music. spinal cord stimulation for me is music and mathematics. Here I wrote down the definition of music as I found it in the Merriam-Webster dictionary, the science or art of ordering tones or sounds in succession, in combination, and in temporal relationships to produce a composition having unity and continuity. If you replace the word tones or sounds there with electrical impulses, this is my definition of spinal cord stimulation. And it is important because we know, and colleagues presented that at NAS, at a big conference 2015, North American Neuromodulation Society meeting, that different types of stimulation with paresthesias, without paresthesias, are actually activating different areas in the brain and activating different mechanisms of action. A new concept now in spinal cord stimulation is this all-in-one surgery versus the trial. Usually or traditionally, we first implanted leads, we tested for 1, 2, 3, or 4 weeks, and when the patient was satisfied, we connected these leads to the battery. Now, there is a new trend starting from the United Kingdom in COVID times that the colleagues simply implant the leads. They are testing intraoperatively, and if they are satisfied with the result, they connect during the same surgery the leads to an IPG. And there are corresponding publications, one of them published in Neuromodulation, showing that if we do the spinal cord stimulation trials in our centers, and we have more or less 85% success rates, or in other words, if 85% of the patients are satisfied during the trial, then in the future, we don't need to do any trials. We can implant during the first surgery a rechargeable IPG, which is a little bit more expensive. If in our center we have a success rate during trials till now of, let's say, 55%, then we can still implant during the first surgery a non-rechargeable IPG without an extensive trial. Non-rechargeable IPGs are, of course, not so expensive. And the colleagues here in the United Kingdom also wrote down how much money we can save. Clinical speaking now, the advantage of this approach is that if we don't do an extended trial, we have less infections, less punctures in the spinal canal, less productivity losses. And a very important question is if our trials are really predictive of long-term outcomes. And here comes a second paper from Samuel Dabe and his team published in Pain, a very good journal, showing that these clinical trials do have a sensitivity of 100%, but a specificity of only 8%. And they conclude that although these trials may have some diagnostic utility, they provide no patient outcome benefits. So in the United Kingdom, we have now the trend to directly implant LINs and IPGs. This is not the case in other countries in Europe, such as in Germany. In my hospital in Germany, we are obliged to do a screening trial before implanting the IPG. If you are interested in the topic, you can read my editorial in the International Journal of Neurosurgery if we need trial spinal cord stimulation. I sincerely hope that it is not boring for you till now, and let's move to the second part, how we got to the systems that we have today. Once again, the gold standard is spinal cord stimulation, the idea. And this is an animation coming from a
Chronic pain can arise from numerous conditions and have many negative impacts on a person's life. Hyperactivity of the wide dynamic range neurons, or WDRs, which project pain signals to the brain, is believed to contribute to chronic pain. The goal of spinal cord stimulation is to suppress this neural hyperactivity and therefore reduce pain signaling to the brain. Treatment for chronic back and leg pain includes the use of traditional spinal cord stimulation, SCS, in which dorsal column fibers are targeted to reduce pain. Traditional SCS delivers strong low-frequency pulses to activate these dorsal column fibers, generating paresthesia, a tingling sensation that must cover the patient's painful area. Obtaining and maintaining paresthesia coverage for back pain can be difficult, leading to poor long-term outcomes. HF10 therapy has been uniquely developed as a more efficacious and paresthesia-free therapy. Rather than stimulating the dorsal columns, it is believed to work by more directly targeting the dorsal horn, using consistent lead placement proximal to the painful spinal segments and a high frequency of 10 kHz. The result is greater neural inhibition and thus greater efficacy.
We have also another type of stimulation, this burst or burst DR stimulation. Here we have packets of high frequency pulses with a pulse width of 1000 microseconds, and we have 5 pulses per second. And this is important because there are publications showing that the tonic stimulation can affect only the lateral pathway of pain, a pathway which is responsible for the perception of pain. But burst stimulation and possibly high-frequency stimulation can also activate the medial pathway, which is responsible for the affective components of the pain, our emotional reaction to pain or the attention we're paying to the pain signals. We have also the technology of the combination therapy. Here we can apply 2 different waveforms for one pain area, or we can select 2 different waveforms for 2 different areas. And what is really interesting now is to apply all these waveforms sequentially, with the hope that in the future, in the next years, the patients will not develop this loss of efficacy. If you're interested in this combination therapy, you could read my editorial in the International Journal of Neurosurgery, of course, free of charge. And we were very happy and very proud in September 2018 to be the first European center implanting this neurostimulator, which was able to provide this combination therapy, all these waveforms combined. And even more happy 2 years later to be once again the first European center implanting the MRI compatible version of this IPG, because the batteries, the IPGs, the neurostimulators would be nice to have all these waveforms there, but they should be full body MRI compatible, because our patients have many other problems and very frequently they need also MRI controls. A new technology is this pairing of frequencies. You see here, we can have a tonic stimulation, then high frequency, then once again, tonic stimulation or burst and high frequency, not combined at the same time, but one after the other. Closed loop technology first appeared in neuromodulation as a publication in 2017, and this shows the concept of this therapy. The lead is stimulating, captures an ECAP, these evoked compound action potentials, compare the amplitude with a preset point, calculate a new stimulus, and then generates the stimulus. And once again, the lead is capturing these evoked compound action potentials. On the lower part of the screen, you see these open loop stimulation systems, the traditional systems. You see the stimulation, the black line, does not always stay within the therapeutic window. It depends on several factors. If the patient is sitting, is coughing, is walking in place, meaning that sometimes the patient is getting more electrical current than he needs, or sometimes less. If he gets more, then he gets more pain. We have a hyperstimulation. If he gets less, we don't actually help him. With the closed loop stimulation systems, you see that the black line, the stimulation, stays almost always within this therapeutic window. It doesn't really matter if the patient is standing, sitting, or doing something differently, meaning that we can deliver a specific amount of energy without causing any hyperstimulation or hypostimulation. And this is an animation showing this concept. You have 2 leads here. You can use the therapy with one lead. We stimulate. Because of the stimulation, we have this red line, this ECAPs, this evoked compound action potential. The lead has the ability to capture this ECAPs, measure it, and then offer a new stimulation. If you open a new neurophysiology book, you will see this ECAP with 2 positive waves, 1 negative one. It's about calcium and natrium channels opening and closing. But in real life, you see in the operating room something like that. The important thing here is that now, for the very first time, we have a very objective measure of what we are doing in the spinal cord when we are applying electrical impulses. And we have studies, the AVAL study coming from Australia. We have the EVOKE study coming from the United States. We have results after 2 years, and now we have also results after 3 years. And I combined them also in a table without the 3-year results. What's really impressive here is that after 2 years, almost 80% of the patients have more than 50% pain relief. We have 46% of the patients who are profound responders. Profound responders means that our patients will have a pain relief of more than 80%. And even more importantly, for me at least, that almost 67% of patients have eliminated or even reduced opioid intake. Another algorithm is DTM, differential target multiplex. With this algorithm, we can stimulate the neurons, we can stimulate the glial cells. And why is this important? Because the glial cells outnumber neurons in the spinal cord. The ratio is 12:1. There are many, many more. And they must play a role. They are involved in many processes such as neuroinflammation, amplification, modulation, and distortion of afferent sensory signals. So if we stimulate them as well, that might be even more beneficial. There are publications in rats showing that this waveform can reduce the mechanical and thermal hypersensitivity. There are publications in humans showing that in humans, this waveform can reduce back pain, also leg pain efficiently. And this is how the IEPG is looking and how the leads are placed. We need 2 leads covering an area from T8 till 210. We have 4 programs that are running in a parallel fashion, 1 basic program and 3 prime programs. It's also subperception. The newest thing in the spinal cord stimulation field is the fast-acting subperception therapy, FAST algorithm. This is a waveform with a frequency of 90 Hz, but no tickling sensation.
Professor Warren Grill of Duke University recently explored the impact of surround inhibition on SCS. Here's how it works. In the gate control theory, small sensory fibers send pain signals to the wide dynamic range or WDR neurons, which are then transmitted to the brain. Conventional SCS activates larger sensory A-beta fibers from the center area of pain. These fibers activate inhibitory neurons, which limit WDR firing and immediately reduce pain, despite also causing some WDR excitation. Conventional SCS also activates some sensory A-beta fibers from the region surrounding the painful center. These fibers only engage inhibition without exciting the center WDR neuron, providing additional immediate pain relief. Using the proprietary Illumina 3D algorithm, we're able to more precisely target the optimal location, covering more of the surround fibers. Combining Illumina 3D targeting with the proper neural dose and a unique active recharge waveform, FAST is designed to preferentially engage these surround fibers while minimizing center excitation. As a result, patients can experience profound paresthesia-free pain relief before they leave your clinic.
So we have a new mechanism of action. And we have clinical results. These are results after 6 months, but they are the same after 1 year as well. We have more than 80% pain relief in these patients. And what's really impressive is that this pain relief comes within seconds or minutes. In average, in this series of patients, within 11 minutes. And what's even more interestingly is this charge per second, the energy usage. If you compare this stimulation, this FAST algorithm, with 10 kilohertz stimulation, you see that we're using 95% lower energy. And why is this important? Because if we're using lower energy, the patients don't have to recharge their system frequently, and the life expectancy of these batteries is much, much longer. Once again, spinal cord stimulation is not a new therapy. It has more than 50 years old history, and we have many data. We have basic science, preclinical studies, we have case studies, we have retrospective studies, we have prospective studies, we have randomized controlled trials which support the use of this therapy in chronic pain patients with back pain or other forms of chronic pain. All companies are doing such studies. These are coming from a specific company. They are real-world studies, or RCTs that are proving that this therapy can be useful. Two very interesting studies are this PROCO study, where the colleagues try to evaluate if it's really important to stimulate with 10 kilohertz or with 7 kilohertz or with 4 kilohertz or with 1 kilohertz. And they actually found that all these frequencies provide more or less the same pain relief, but the 1 kilohertz stimulation has a much lower charge per second. We don't need so much energy. The second publication, there's a Halo study, went one step further and evaluated what happens if we keep reducing the frequency from 1000 hertz till to 10 hertz. And they saw that actually the pain relief was pretty good with all these frequencies. The best results were achieved with 200 hertz. And the same is true with the charge per second. The lower the frequency, the lower the charge per second. Hopefully you are still with me, because I would like to present to you our study from my department, a rescue study published also in Neuromodulation in 2020. Back then, the journal had an impact factor of 4.7. It was about patients with a spinal cord stimulation system who came back after years with more pain, and they wanted to have their system explanted. So who could either explant the system or try to use different types of stimulation, or even this combination therapy with combination of different waveforms. So we externalized the leads, we tested with an external stimulator, and we saw that 8 patients did not benefit from it, so we expanded the system, but 29 patients did respond to this combination therapy. We follow up these 29 patients, and after 1 year, we saw that they had a pain relief of 43%. Please remember, it was about patients who were ready to have their system explanted. And let's move to the third part, why I think a new era has begun. A new era has begun because now we have different distinct mechanisms of action. We have different waveforms. We can stimulate the dorsal horns, we can stimulate the dorsal columns, we can stimulate both of them at the same time. And this leads to clinically significant improvement. You see the OD, the Oswester Disability Index, becomes better. These are 3 studies coming from 3 different companies showing that the patients with spinal cord stimulation therapy have less disability. Patients are satisfied with the therapy. 4 studies, 2 are coming from one company, the other 2 are coming from 2 different companies, showing that all patients are satisfied with this therapy. And this is an algorithm we had in my department some years ago about patients with back pain and spinal cord stimulation. We had to know if the patients had only back pain, which was local, then we might try with subcutaneous leads, or diffuse, then we might try with a high frequency stimulation. If the patient had only leg pain after a surgery in the lumbar spine, we started with a tonic stimulation, then used burst stimulation, 1 or 2 leads. This is, as you can see here, an old algorithm. Nowadays, with all waveforms that are available, we can achieve pretty good results without having to use subcutaneous leads. What about the future of this therapy? The future could be more spinal cord stimulation systems or different frequencies. For example, this is a company offering, not in the European market, in the United States as a trial, a system with 500 kilohertz for some minutes per day. You probably heard about the brain-computer interfaces that are using in patients with stroke, trauma, or neuromuscular diseases, patients with paralysis. Maybe this is the way to go in the future for chronic pain patients. We can use the endovascular access to place such stents in small vessels in the brain and then influence the pain areas and reduce the pain. The future is more data. All companies have many applications. They are trying to collect subjective and objective data and use this data in order to see if they can predict in specific pain types if specific waveforms are more successful than others. And this is where artificial intelligence could help us. Artificial intelligence is something that we're using in everyday life. For example, in Germany, they use it to complete the 10th Symphony of Beethoven. You know, Beethoven died before completing it. So musicians, with the help of artificial intelligence, managed to finish it and present it in Bonn in 2021. We can use artificial intelligence to use all this data that we are now have available, how many hours the patients are sleeping, how big distances they can walk, in order to predict which patients could respond better to better waveforms. We have the option of merged reality. Here we can blend two video streams. For example, I'm in Cologne. I try to program a patient. My sales rep, the company representative, is another city. He can see what I'm seeing on my laptop, and he can show me on my iPhone what I should do to program the patient more efficiently. We have the option for remote programming. This is another software, Heart Connect, because it started from the cardiology colleagues. Here you can see I can be in my office. We can have a sales rep in the room of the patient, of course, and you can have a second sales rep for a company who is located in another city or even in another country or in even another continent. And we can all work together in real time and provide the best result to our patients. Spinal cord stimulation could have some more exotic indications. For example, the respiratory function in patients with complete spinal cord injury. Patients who need a mechanical ventilation. Spinal cord stimulation leads place somewhere between T2 and T5 can facilitate the respiratory function and reduce the complications which patients are having when they're connecting to a mechanical ventilator. This is work coming from our department showing how fast this new algorithm, subperception algorithm, can help even patients with mixed pain, because traditionally we know spinal cord stimulation can help people with neuropathic pain, not with nociceptive pain. Now we are starting to see that with the newer waveforms, and especially with fast, we can treat also patients with a combination of neuropathic and nociceptive pain. Patients with subarachnoid hemorrhage. Colleagues in the United States used a lead in the cervical spinal cord within 3 days after the rupture of the aneurysm for 10 or 14 days stimulation, tonic stimulation, to see if they can improve the perfusion in the brain. These are, of course, the first attempts, but it seems very promising. A very nice publication in the European Journal of Pain about the referral of patients and selection of patients for spinal cord stimulation. And based on this publication, a company made up a new website, this eHealth tool. It's free of charge. You can register. You can give the clinical data and the psychological data of your patients, and the tool will provide a recommendation if the patient is a good or a bad candidate for spinal cord stimulation. This tool was intended to be used by general practitioners or neurologists just to increase the rate of referrals to neuromodulation centers. Above all, leads are good, waveforms are good, neurostimulators are good, but above all, we need compassion, which is, as the American philosopher wrote here, the antitoxin of the soul. Compassion for our patients, but also compassion for the physicians, for our colleagues as well. This is an article we published here in Germany. It's about COVID-19 and colleagues using in the surgery departments or anesthesia departments with burnt out and dependence. And it seems to be a big problem. So we have to look after or to take care of our colleagues as well. We need a collaboration, a national collaboration within our countries, an international collaboration with all colleagues from all countries. This is why webinars like this we're having today helps a lot in raising awareness and building up networks. Collaboration with the sales reps of the companies in many hospitals, in mine as well, are doing the programming in our patients. And these are people who are working with us in Cologne, and they are providing excellent clinical results. I'm very grateful to them. This is why I would like to thank them. If you are not already doing it, please follow the social media accounts of the Journal of Neuromodulation, the official journal of the International Neuromodulation Society. If you're interested in the topic, you could further read these two books, The Handbook of Neuromodulation, I was editor there, or The Recent Developments of Spinal Cord Stimulation, I wrote this article. If you have any questions, I would be glad to answer them. If not now, this is my email address. Anytime, please drop me an email. I will get back to you. Thank you very much for your attention. Once again, that is Syria and Neurosurgical TV. Thank you very much for the invitation and the whole organization.
Well, thank you very much for the presentation and the extremely worthy information that we are mainly in Syria new to them. Okay, you have been saying that functional neurosurgery and these types of stimulation are not something new, but in Syria, due to the recent circumstances in general, we still have this technology is very, very young. So I am extremely grateful to have you today speaking about this. We have been also for the friends and colleagues in Syria, we have been contacting a few neurosurgeons to speak about these technologies in our country. And we have some experiences in many hospitals that we would love to spot the light on in the few next days regarding especially the trigeminal stimulation, this nerve stimulation. So thank you very much for the presentation. If there is any questions, you may ask them now. We may receive the questions. I have something that arose in my mind right now, like we have been talking about the pain technology. Could we have a short overview about the pathophysiology of pain and how these are transmitted? We have many medical students right now who are seeing, not all neurosurgeons. So if we can speak a little bit about this idea.
The pathophysiology of pain is something you can find in every textbook. This is not interesting. What's really interesting is how spinal cord stimulation is actually working. And the quick answer is
exactly.
no. There are many publications since many, many years with animals, with rats, mice, pigs, sheep. There are many publications with humans. There are many proposed mechanisms of action, but how exactly this works, we don't really know. We know, based on publications, that when we stimulate, we are altering the way that the spinal cord functions at the level of the stimulation, and this is made mainly with the neurotransmitters which are released or not released in this area. Another way is the direct activation of inhibitory neurons in the spinal cord area, in the spinal cord segment. But at the same time, it seems that when the electrical impulses are traveling up to the brain, then certain brain centers are activated and are descending information to the spinal cord, inhibiting the pain signals. But this is really interesting. Although we have this therapy in so many years, we don't really know how it works.
Any other questions from the panelists? You know, Georgio, I'm not a neurosurgeon. I'm just asking this question from a ex-general practitioner's mind, but certainly chronic pain, you don't have to say how common that is worldwide. And being offered a relatively non-invasive way to treat it. So you're speaking to a segment of the patient population that's really willing to listen, correct?
Actually, the patients are the only ones who really want to listen. Our colleagues are not really interested in these therapies because of different reasons. There are some exceptions, of course, to the rule, but the majority of colleagues, even though they are informed about these therapies, they are not passing this information to the patients. This is a huge problem.
Oh, okay.
So this is why I think the right way to go is to go directly to the patients, to association of patients, and inform them directly about the options that neuromodulation has to offer. It's not only about spinal cord stimulation. We have peripheral nerve stimulation, we have motor cortex stimulation, we have deep brain stimulation, we have intrathecal therapies, pump therapies, and many, many other things that could help, but the patients should be aware of them.
Yeah, yes, we were speaking before about your presence on social media. It's important that you educate, like you say. So nowadays with the internet, the patient can get directly educated and can hear about things like this, options like this. George Bashur, I believe, had a question. George, you still have a question there? Can you get on camera? George Bashur. There you are. Hey, George, turn your camera on.
Yeah. Just 1 second.
Okay,
Can you hear me?
yes, we'd like to meet you.
Yeah, one second. I'll try to turn the camera on.
Yeah, do your best. It's no huge deal if you can't do it. This is part of the image, Georgio, showing your face.
So, yeah, I'm trying to show my face, but the camera isn't working.
Okay,
Sorry
that's
for the
okay.
camera.
Go ahead.
My
go ahead.
question, okay, my question is about the future of this surgery, about the cost of the future of surgery. Could this type of let's say treatment for pain be kind of cost efficient in the future, maybe turn over the cost of the medication that are used to mitigate this pain? Can this surgery just fix the whole issue of the cost efficiency?
Thank you for the question. If the indication before implanting the system is correct, then almost all patients are benefiting from it. They are keeping the system for many, many years. They are reducing the consumption of medications. They are not having so many hospitalizations. They are not coming to the emergency department so frequently. They can participate actively in social life and in work, meaning that the society does not lose any money. So in the long run, let's say if the system stays within the body of the patient for at least 3 years after the implantation, then the therapy is indeed cost effective, because we have the direct and the indirect cost. Direct cost is how a spinal cord stimulation is costing, how much a surgery is costing. But please consider how much money we save if the patients are satisfied with this therapy. Then they don't have to get any drugs, or they get much less drugs. They don't go to the hospitals. So there are many publications you can look up in PubMed, showing that the therapy is indeed cost effective. It is an expensive therapy in the beginning, but in the long run, it's a cheap therapy. As long, once again, the indication is the right one. We cannot start operating all patients with pain with such devices. This is not right, and this will not help them. But if you choose wisely the patients, then the results are clinically good, and the society benefits from it from the financial point of view.
Okay, I believe
Yeah, thank you,
Nahar.
Dr. Jonas. But my question is specifically about and the future cost of this surgery. And is there any studies that have been done to prove this cost efficiency in this indirect factors that you mentioned?
There are many
about
publications. Just go to PubMed and type in spinal cord stimulation and cost effectiveness. There are already many publications there. Most of them are coming from the United Kingdom. It is proven that it is a cost-efficient therapy. The problem is that in the beginning, it is an expensive therapy, mainly because of the cost of the implants. And the companies which are selling these implants are not willing to reduce the cost because they want to keep on researching on new technologies. But once again, even though it's an expensive therapy, in the beginning, after 3 or 5 years, you have reached this point where you can say that the therapy is much cheaper than the conventional medical management. This is not something I'm saying. Okay, please look it up. Go to PubMed and see all the relevant publications. They're out there. Most of them free of charge as well.
Okay, Nahar, I believe you had a question. Nahar Ismail.
Yeah,
Well, I'm trying to contact Nahar on the.
No, he's here.
Yes,
He's on camera
I
now.
do.
He's on
Okay.
camera
I'm
now.
here.
Okay.
Yeah.
I don't know if my camera is working.
There it is. Perfect.
Hello,
Perfect.
Professor Matthias. First of all, thank you for this valuable lecture. It has been an absolute pleasure. It has been very informative. My question is regarding the future of this technology. I've read recently about this topic is also about pain management, but about a future application of this technology. I've read the past few days.
Who can guess what you want to ask?
It looks like he got frozen there.
Future applications, but in which area is a question. There are many future applications of this therapy, but what did the colleague wanted to ask exactly? I can proactively say, because the people keep asking this question, what is happening in case of patients with spinal cord injury if they can walk again using this therapy? And the answer is, to this point, no. There are very few specialized centers. One of them is in Lausanne, in Switzerland, working on this topic. But at this point, I would not say that spinal cord stimulation can help patients walk again. It can help with chronic pain. It can help with the autonomic functions, blood pressure, for example, of these patients, or bladder function of these patients, not for mobilization. But please ask the question again. We cannot hear you. Would you like to type?
You're muted. You're muted now.
Now, can you hear me now?
Yeah, perfect. Go ahead.
I'm sorry, the connection just went out. The connection is a little bit bad. My question was, I did not read a lot about this specific case, but they said in a certain interview that they repurposed this technology to allow electrodes from the patient's brain and the patient's spine to communicate together, so that the spine is stimulated in a similar fashion, or this area of the spine that is below the injury is stimulated in a similar fashion that how it would be stimulated in a healthy patient. So my question is, can this technology in the future be used to send neural impulses between the brain and the severed part of a spinal cord, for example, in a patient with a car accident or a severe trauma to the spine, something resulting in a paralytic, in a quadriplegic patient, for example?
You are speaking about the work of the Lausanne team in Switzerland. It could be possible, but it will take time. The colleagues in Lausanne are working on it. They are trying actually to bypass the position of the injury using an implant in the brain and activating the spinal cord. This is something that they prove that can be done. But from the point of proving that in 5 or 10 patients till it becomes a common practice in all hospitals, in all countries, it will take years at least from now. So if you have a patient asking about it, I would say no at this point, but this is something that is doable and will be done in the next 5 to 10 years, I believe.
Thank you very much.
Somebody asked something about studies, how people can get involved.
Okay, so we have one more question from Amita. Yes, exactly. That's Amita. She's asking, how can we get involved in collaborative project studies? Is there a platform for this?
There's no platform for this. If somebody is interested, should contact directly the departments which are doing the research and see if there are any open positions or any open positions to participate in such research programs. There's not a platform, no, as long as I know.
Yeah, we need to put your email again on the chat. Can you put the email of the doctor on the chat, Allah, please?
Here you are.
There we go. Okay.
Yes, okay, sure.
Okay, there we go. No problem.
But you can find also, if you just write in Google Madison University Hospital, you will find the website of my department, and maybe it's there as well.
Okay, very good. Allah, I'd like to thank you for coordinating things, and of course, Georgio, thank you. Keep maintaining your presence on the internet. You're very well spread out your education. But a great tool, Georgio, for education. I wish more people would use it. And okay, that's all the time we have, and thanks everyone for coming. And,
thank you very much.
Okay, we'll see you shortly.
Thank you very much for everything.
Thanks. Thanks to all of you.
Bye bye. Bye.